This short movie explains the indication for the so-called one-stage method. The two most popular correction methods for pectus excavatum are the NAS procedure and the Leavitt procedure. These methods require two-stage surgical interventions. In these methods, the surgeon corrects the patient's thorax shape in the first operation and sustains the corrected shape with metal bars. The surgeon removes these bars in the second operation. Some patients feel receiving two operations is bothersome. Therefore, some surgeons have developed an original method to avoid the secondary surgery and to complete treatment with a single operation. They call this method one-stage correction or the SCE method. SCE means Sternum-Costal Elevation. The SCE method does enable the correction of pectus excavatum with only a single operation. So, I have employed this method for some of my patients. However, very rarely. This is because for most patients, the SCE method is not suitable. The SCE method is suitable only for patients who meet two conditions. First, the deformity is symmetric. Second, concavity is localized only to the pit of the stomach. For instance, look at these two patients. With this patient, only the pit of the stomach is concave. The SCE method is suitable for this patient. However, for this patient, the SCE method is not suitable because the deformity involves a wide region of the chest. I will explain this reason for this in the following. First, let me explain how the SCE method is conducted. This figure represents a thorax that is suitable for the SCE method. The white object at the center of the figure represents the sternum. The pink objects represent costal cartilages. Some deformed cartilages attach to the end of the sternum. Only the pit of the stomach is sunken. Other parts of the thorax have no deformity. The costal cartilages are detached from one end of the sternum. Then they are reformed and attached to the end of the sternum. Next, the cartilages are sewn to the end of the sternum by using threads. This is the essential point of the SCE method. Since threads are used for the fixation of the costal cartilages, unlike metal bars, it isn't necessary to remove them in the second operation. I explained that this method, the SCE method, is suitable for the right side patient, but isn't suitable for the left side patient. Next, I will explain the reason. Let's model the thorax from a dynamic structural viewpoint. Suppose the side view of the thorax. The sternum can be modeled as a beam sticking out from a cliff, and the costal cartilages can be modeled as a cable hanging on the edge of the beam. The type of the thorax that is suitable for the SCE method is modeled like this figure. The sternum is intact. Only the costal cartilages at the pit of the stomach are deformed. This structure can be simulated as a condition in which a deformed cable is attached to the end of the intact beam. To correct the deformity, we only need to detach the cable and reconnect it to the end of the beam. This correction provides decent stability to the fall structure because the beam is already stable before correction. However, with most pectus excavatum patients, it is not only the costal cartilages that are sagging. The sternum is also sagging. This condition is modeled as shown in this figure. To correct chests presenting such deformities, we need to correct the sternum in addition to costal cartilages. This situation is modeled as shown in the figure. This is a three-dimensional demonstration of a thorax presenting with this type of deformity. The sternum, as well as some costal cartilages, present deformity. We need to divide the sternum to isolate and mobilize its deformed part. Then we elevate the deformed part. With a plate and screws, the elevated sternum is reconnected to the other part of the sternum. Thus, the sternum is kept at the correct position. Besides the sternum, costal cartilages are also deformed. They are reformed and attached to the sternum. Now, let's go back to the analogy of the beam and the cable and analyze the dynamic condition of the sternum after correction. In the thoraxes of most patients, not only the costal cartilages but also the sternum is sagging. The beam, which is equivalent to the sternum, is first elevated. The beam is fixed at one end with the plate and screws. The cable is elevated and connected to the other end of the beam. This is equivalent to the reattachment of the costal cartilages. Due to the weight of the beam, intense stress occurs around the screws. The elevated cable also pulls the beam downward. This produces a tendency to rotate. The rotational stress adds to the stress already working around the screws. As a result of the intense stress around the screws loosen and the beam sags over time. Because of this phenomenon, the sternum and the costal cartilages elevated by the SCE method sag over time, causing recurrence of the deformity. In contrast, in the Nass and Reibich procedures, the elevated chest wall is kept at the correct position with metal bars. The metal bars support the chest wall from behind. This supporting system is modeled. Please compare the stability of the elevated structure. The lower model, simulating the Nass and Reibich procedures, is much more stable than the upper model, simulating the SCE method. Even if the cable is attached to the beam is unlikely to sag, since the support of the beam from behind is very stable. Thus, because of the difference in dynamic mechanisms between the SCE method and the Nass and Reibich methods, Recurrence is likely to occur after the SCE method, but is unlikely to occur after the other two methods.